Welcome to my video today.
We'll be discussing concentrated insulin, specifically in this video, U-500 concentrated insulin. For example, we'll be discussing when is it appropriate to use, in what sorts of patients, how do we incorporate this into a insulin regimen, whether it's by injection or via the insulin pump, and of course we'll end with some case studies to contextualize this knowledge. So let us jump into it. So, as stated by Uncle Ben in Spider-Man, with great power comes great responsibility. U-500 can be a real game changer to patients requiring 200 or more units of insulin per day. But again, there's heightened risks with U-500 insulin in a patient or a clinician who's not aware of how to correctly prescribe and administer it. This can lead to a high risk for hypoglycemia and ultimately death. So again, with great power, referring to the U-500, comes great responsibility. So let's discuss what U-500 is. Let's first take a step back and actually discuss what concentrated insulin is. So there are various forms of concentrated insulin on the market. There's 2GO, which is U-300 glargine. There's Humalog U-200 as opposed to U-100. And there's Tresiba, which is degludec U-200. So what does this U followed by a number mean? So typically with U-100, this means there's 100 units of insulin per milliliter. When we see here with U-500, that means 500 units per milliliter. That's 5 times as concentrated as U-100 insulin. And if we look to this picture here, we can see this is a syringe with U-500 insulin, and this is a syringe with U-100 insulin. Despite the differing volumes, this both actually equate to the same units of insulin. It just happens to be in less volume. So U-500 is 5 times as concentrated, meaning there's 80% less volume to get that same amount of units of insulin. And this is where it comes in handy to patients requiring an excess amount of insulin to be injected per day, typically more than 200 units per day. If we were to think about a long-acting insulin pen such as Basaglar, which is glargine, U-100, this only delivers up to 80 units per injection. So imagine if a patient requires 120 units at night, for example. They're very insulin resistant. They'd actually have to take more than one injection at nighttime, and that would be very annoying. Again, the U-100 pens only store up to about 300 units, so within a matter of days, they'd actually have used up that pen and will be required to get another one. So using U-500 can be a real game changer, injecting less volume, so of course it stores more, and allowing less injections per day as a result. When there's less volume, there's actually less cost per unit of insulin, of course, and that's another game changer. So there are drawbacks, as we've said, with great power comes great responsibility. The feared complication of hypoglycemia if this is not used correctly. Lots of healthcare providers actually don't have experience in this unless you're in an endocrine or diabetes related field. You're not going to have a lot of experience when using this, and it's very important for the healthcare professionals to know their limitations. When a patient is admitted to the hospital using U-500, they should get help to manage this patient appropriately. Again, another drawback is as of yet, FDA has not approved U-500 for insulin pumps, so it's off-label usage and requires both the patient and the clinician to be highly aware of what they are doing. So U-500 isn't actually new. It was first introduced in 1952, originally of beef origin, then in 1980 as pork origin, and it wasn't until 1997 that it became what it is now, which is human insulin, and that's why it's called Humulin RU-500. It's human insulin. So there was a form of U-500 known as Act Rapid U-500, but this was withdrawn in 2007. So at the moment, Humulin U-500 is the only 500 insulin on the market. So I like to think of U-500 as the baby between NPH, which is neutral protamine hagedorn, and regular U-100 insulin, the son or daughter of those two insulins combined. So that's because U-500 insulin exhibits both basal, so long-acting background, but also bolus, or fast-acting actions. And again, this can be a game changer for patients who require multiple different injections, some before meals, some at nighttime for the long-acting insulin, whereas just having one type of insulin that can cover both is quite amazing. So it's typically administered 2 to 3 times per day. Of course, as with all insulins, injected subcutaneously or into the fat. And we can see the diagrams here, depending on how you inject it, how the levels in the blood of insulin go up and down. So as I've said, it's typically thought of as the son or daughter when NPH and regular U-100 insulin get together. As we compare U-100 to U-500 here, we see the onset's quite similar, which is why we recommend with regular insulins, we give it 30 minutes before a meal. We see the peak is a bit longer in U-500 insulin, as is the duration of action, up to 24 hours after a single injection. So again, you can see quite clearly that it has some similarities with U-100 and some similarities with NPH, which is an intermediate acting. So let's discuss who should receive U-500 insulin. So as I stated on the previous slide, patients who require 200 units or more per day of insulin are typically candidates for U-500 insulin. We typically see this in patients who are severely insulin resistant. These are patients typically with type 2 diabetes and obesity, something referred to as diabesity. And it was interesting that Eli Lilly and company shared some statistics. Between the years 2008 and 2010, the usage of U-500 insulin increased by 97% because of this pandemic. So in other states, such as post-operative, post-transplant, patients who are severely ill, have a systemic infection, or require high doses of glucocorticoids, these are all situations where patients are going to be very insulin resistant and sometimes require U-500 insulin. Sometimes patients with gestational diabetes mellitus become severely insulin resistant and require U-500 insulin. And another state of severe insulin resistance are lipodystrophic states or certain congenital or acquired forms of this. So let's now discuss how to administer U-500 insulin. So U-500 insulin comes in either a vial and syringe or a quick pen. So if we discuss the quick pen first, this is preferred probably by most patients and professionals. As we see here, it comes in a preloaded pen, adjusts by 5-unit increments, and it contains up to 1,500 units in this pen, so allowing for multiple different injections. It also administers up to 300 units per injection. So as I stated before, imagine a patient requires 120 units of a long-acting insulin at nighttime. If they were to use a U-100, for example, Basaglar pen, where they can only inject up to 80 units, they'd require more than one injection, whereas with the U-500, they can simply give that higher injection unit. And again, 1 unit is equated to 1 unit. If we go back to this slide, we saw that differing volumes equate to the same units of insulin, but that's pre-calculated here already. So we say 1 unit is equal to 1 unit. Now it's a bit more confusing with the U-500 vial and syringes. As we see, this is the vial, contains 20 milliliters, and there's a U-500 syringe, contains up to 250 units per syringe, per injection, and adjusts by 5-unit increments like the pen. Now, the problem with the syringe is that it's very difficult to come by, whether it's insurance reasons, pharmacy stocking. When the syringe is not available, however, patients will then have to use a U-100 syringe, and that's where mathematics calculations and errors occur. Sometimes patients even use a TB syringe, but I really wouldn't recommend that. When using the U-500 syringe, 1 unit equals 1 unit. But when you use the U-100 syringe, we know that U-500 is 5 times as concentrated, so calculations are required. So for example, if a patient was going to take 25 units of U-500 insulin, using a U-100 syringe, we need to divide that by 5, so that would be 5 units of U-500 insulin with a U-100 syringe, because we know U-500 is 5 times as concentrated. Again, if they were to take 100 units on a U-500 syringe, that would be 20 unit marking on a U-100 syringe. Let us discuss how we prescribe U-500 insulin. So the first thing we do is we look at the HbA1c and we assess, is it between 8 to 10%, is it less than 8%, or is it more than 10%? So if it's between 8 to 10%, we recommend a dose-for-dose conversion from U-100 to U-500 insulin. If the A1C is less than 8%, we reduce the U-500 dosage by 10 to 20%. And if the A1C is more than 10%, then we do the opposite. We increase the U-500 dosage by 10 to 20%. With U-500, as I've said, it's typically a 2 to 3 time per day subcutaneous injection. So we need to monitor the the sugar levels. We need to see how effective the injection was. And how we do that is we simply look at the sugar readings before the following meal after we've injected. So for example, if we injected before breakfast, we look at the lunch or dinner readings. If we injected at dinner, we look at the pre-breakfast readings, etc., etc. So what's most important is we calculate the total daily dose of insulin. That's simplified as TDD. And what this means is the basal plus the bolus insulin. So we calculate how much of the total daily dose a patient was previously taken, and then we will change that into a U-500 regimen. Typically, the various papers recommend only using U-500 when patients require 200 or more units per day. I put 150 here as some papers have said 150 could fit to this category, but I would just ignore that for simplicity. So we stratify how much insulin per day the patient is using. Is it between 200 and 300? Is it between 300 to 600, or is it 600 or more? So let's start with a patient requiring 200 to 300 units per day. We would split this into 2 injections per day, 60% in the morning and 40% at night. So for example, 60% would be 30 minutes before breakfast and 40% 30 minutes before dinner, so at 6 p.m. Some papers said you could also try doing 3 injections per day, and as you can see, there's various ways to do this. What is most important is that morning is always higher and evening is always the lowest. That's because we're most resistant in the morning and we're more sensitive at nighttime and do not want to cause hypoglycemia. So how do we adjust in this domain? So various papers suggest if the sugars are within 50 milligrams per deciliter of the target, then we just simply adjust either up or down by 5 units. If we're more than 50 milligrams per deciliter within our target, for example, a target could be 120 milligrams per deciliter, then we adjust by 10 units. Now I've put in brackets plus or minus basal, and although typically U-500 is used on its own, so for example, it covers the meals, but it also has the long-acting background effect. Sometimes U-500 is added solely for meal coverage. It's only bolus, and patients continue their basal or long-acting insulin, such as glargine, such as NPH or Detamir. Now, how to use U-500 as just a bolus injection requires expert advice, but typically, in this case, the proportion of basal to bolus insulin that the patient used would remain the same before the U-500 therapy was introduced. And there would be very careful adjustments of the basal component following the fasting sugar levels. So when we get between 300 to 600 units, we know that 2 injections per day is not really effective, and we consider 3 or 4 injections. For simplicity, it's probably easier to always start with the lower number of injections per day. Again, as we said, the highest in the morning, the lowest at nighttime. So that could be 40%, 30%, 30%. Examples being before breakfast, before dinner, before lunch, and before dinner. And again, as you see, there's many different ways to do this. To adjust in this case, we look at the blood sugar levels. If they're within 100 milligrams per deciliter of a target, then we adjust by 25 units. If they're more than 100 milligrams per deciliter within the target, then we adjust by 50 units. And then we get on to the final section, which is someone requiring more than 600 units of insulin per day. We recommend 4 injections per day. And again, the highest is in the morning, lowest is at nighttime. So an example could be 30, 30, 30, and 10%. And we adjust by 50 units in this category. So this example would be before breakfast, before lunch, before dinner, and perhaps a late night snack at 10 p.m. So again, this slide is very important. I'll go over it one more time very briefly. We look at the A1C and we adjust it depending whether it's between 8 to 10%, it's less than 8, or it's higher than 10. We look at the total daily dose of insulin and we stratify, is it between 200 to 300? If so, we start with 2 injections per day, 60% of the total daily dose in the morning, 40% at nighttime. If it's between 300 to 600, we start with 3 injections per day. An example could be 40% in the morning, 30% at lunchtime, and 30% at nighttime. When we're more than 600 units per day, we give 30% in the morning, 30% at lunch, 30% at dinner, and 10% at nighttime. Okay, let us move on to the next slide. So let's discuss insulin pump and U-500 usage. So it's very important to note that this is actually off-label. There's no FDA approval. And this is because at the moment, insulin pumps use U-100 reservoir insulin, and they measure a certain volume, and that certain volume is known as 1 unit. And as we've seen in the previous slide, that the volumes differ for what constitutes a unit in U-500 versus U-100. So insulin pumps don't yet have that ability to determine whether this is U-500 or U-100 insulin. So there's a high room for error and hypoglycemia if the patient and the clinician are not aware of this. So under normal conditions, when it says 1 unit on a pump, that means 1 unit. But we know with U-500 insulin, 1 pump unit is actually 5 units. When it says 1 unit on the pump, we know it's actually 5 units in the system. And this is why the patient must be educated. They must be able to interpret their pump with caution. So for example, if a patient is carbohydrate counting and they're very insulin resistant, 1 unit covers 5 grams. When it says 1 pump unit, so when it says 1 unit on their pump, we call that pump unit. This is actually 5 units in their system, so we times it by 5. We know 5 units, and it's actually going to cover 25 grams. So although it'll say 1 unit on the pump, or as we say 1 pump unit, we need to pretend that it covers 25 grams. Similar to the sensitivity factor, let's say they're very resistant and 1 unit only lowers the sugars by 12 milligrams per deciliter. Although it'll say 1 unit on the pump, we know secretly this is actually 5 units because it's U-500 insulin. So we times what it would lower by 5. So although it says 1 unit on the pump, we would assume this lowers it by 60 milligrams per deciliter because it's 5 units. So an insulin pump uses one type of insulin for both the basal and bolus. And because of this, the basal rate needs to be lowered. So examples are using either 50% of the total daily dose or 20%. It's probably best to start low and go slow. Again, this requires expert opinion and is used off-label. So we don't want to give continual boluses because we know U-500 lasts longer in the system, can cause insulin stacking and hypoglycemia. We also need to change the active insulin time. So typically in a pump, this is 3 to 4 hours. With U-500, we should put it at 6 hours. So again, something I want to mention is that with more than 600 units per day of insulin required, we actually don't recommend using an insulin pump because the large amount of volume that is being injected will likely impair the absorption at the catheter site. There'll be altered pharmacokinetics and really just a high risk for error. Additionally, patients will have to continually change their reservoir. So we would recommend it between 200 to 600 units, but not more than 600 units. So as I said, the basal rate needs to be lowered. So let's assume that the basal rate is 20% of the total daily dose. That means the remaining bolus should equate to 80% of the total daily dose. So for example, we can see here that would be 30% of the total daily dose before breakfast, 30% before lunch, and 20% before dinner. That's assuming we have 3 meals. We could also split this across 4 meals. And as we see, again, the highest is in the morning, the lowest is at night. It's important that the bolus at bedtime is not more than 10% of the total daily dose of insulin because we do not want to cause overnight hypoglycemia. That is very dangerous. So first case study, Raphael is a 47-year-old gentleman with a 20-plus year history of type 2 diabetes mellitus. Now we see his current HbA1c is 9.6%. His current medication regimen includes 60 units of Lantus twice a day and 30 units of Novolog before each meal, administered 3 times per day. So the question is asking if we can convert his current regimen to a concentrated U-500 injectable regimen. So not using the pump, an injectable regimen with either the vial and syringe or the quick pen. So the first thing we do is we consider we're only going to use U-500 from now on. We're not going to be using the Lantus and U-500 as that would be too confusing for this patient. So the first thing we do is we calculate what is his total daily doses of insulin. He uses 60 units twice a day and 30 units 3 times a day. So that is 120 plus 90, so 210 units per day. He requires more than 200 units today and would be a candidate for U-500 insulin. We then look at his glycated hemoglobin. It is 9.6%, so between 8 and 10%, so we do a dose-to-dose conversion. Now we go to the U-500 regimen. As we said, between 200 to 300 units per day, it's best to start with 2 injections per day, 60% 30 minutes before breakfast and 40% 30 minutes before dinner. So in this case, 60% would be 126 units, which we can round to 125 units because we know the pens only adjust by 5-unit increments. And dinner time would be 84 units, so we can round to 85 units. So again, this would equate to 125 units in the morning and 85 units at nighttime. Let's go on to another case study. So this is actually a continuation where the same patient, he's taught the concepts of U-500 insulin, and he's really attracted to only having to give 2 injections per day. We can imagine the large amount of injections he'd have to have given previously on his prior regimen. His insurance will not cover the quick pen, and there's actually a backlog on the U-500 syringes as local pharmacy. So as a result, our patient is now taught how to use a U-100 syringe. We see this is his current U-500 regimen, 125 units in the morning and 85 units at nighttime. So the question is asking, which of the following correctly demonstrates the administration via a U-100 syringe? Is it 12 units in the morning and 18 units at night? Is it 12 units in the morning, 15 units at night? Is it 25 units in the morning, 17 units at night? Is it 35 units in the morning and 27 units at night? Or is it 25 units in the morning and 19 units at night? So we need to remember that when we're using a U-100 syringe, we need to divide by 5 because we know U-500 is 5 times as concentrated as U-100. So when we divide 125 divided by 5, we're going to get 25. So we know he's taking 25 units in the morning.
And therefore is taking 17 units at night. It's important to realize that with the U-100 syringe, they can typically adjust by 1-unit increments. So there may not be a need to round up or down.
So let us move on to another case study. So we have a patient with an HbA1c of 9.4% and is currently taking 60 units of Lantus twice a day and 40 units of Novolog before each meal. Let's assume that's 3 meals a day. So the patient's interested in going onto a U-500 pump, but at the moment is not interested in carbohydrate counting. So how would we solve this? The first thing we consider is that he's taking 240 units of insulin per day, so he definitely is a candidate for U-500 therapy. His A1C is between 8 and 10%, so we don't need to adjust his total daily dose. We don't need to increase or decrease by 10 to 20%. As I stated, we need to give a lower basal rate when a patient is using U-500 because U-500 lasts for a long time in the system and we don't want a higher basal rate with a high risk for hypoglycemia. So 20% of 240 units is 48 units. So again, we could round this down to 45 or we could round this up to 50. We need to divide this by 24 because that's how much of the basal rate we will give per hour, how many units per hour. So this equates to 1.88 units per hour. Now with an insulin pump, we know we give different basal rates throughout the day. I would consider a slightly lower basal rate overnight, so between 9 p.m. to 5 a.m. as an example. This would appear on a pump 9 p.m. to 12 a.m. and then 12 a.m. to 5 a.m., but we would consider a slightly lower rate, such as 1.6. And in the early hours of the morning, we could consider increasing the rate to combat the dawn phenomenon, so we could increase it to 2.0. Now, of course, we're using U-500. Pumps are not programmed to use U-500, so we need to manually calculate. We need to divide this by 5. What would the basal rate appear on the pump settings? And we divide that by 5. So 1.6 divided by 5 would be 0.3 units per hour, and that would be overnight. And 2 divided by 5 would be 0.4 units per hour, which would be in the early hours of the morning to combat the dawn phenomenon. And we'd likely keep that until 9 p.m. and we'd assess it for a few days or weeks and then adjust further. So now the boluses, as we said, we've chosen 20% to be the basal rate, so that means the remaining 80% must be made up from boluses. So 30% of the total daily dose to cover breakfast, 30% of 240 is 72 units. We can round that down to 70 units for simplicity, and then 25 to cover lunch and dinner, which would be 60 units. Again, we're using a pump which is not programmed to use U-500 insulin, so we need to divide it by 5. This would mean 70 divided by 5 is 14 units before breakfast, and 60 divided by 5 would be 12 units before lunch and before dinner. Now it says this patient doesn't want a carbohydrate count, so we need to consider the correction factor. And we typically get a correction factor by using the formula 1800 divided by total daily dose. So in this case, 1800 divided by 240, which would be 7.5. It would be safe if we round up to 8 because counterintuitively, the higher the sensitivity factor is, the less insulin we actually need to give. So we'd want to play it safe and suggest this is 8. Again, we're using an insulin pump whereby it is not programmed to recognize U-500 insulin. So we need to remember U-500 is 5 times as concentrated. So it's going to say 1 unit on the pump, or 1 pump unit as we say, but we need to times whatever we see by 5, so that realistically 1 unit on the pump is going to lower our sugars by 40 milligrams per deciliter. So let's go on to another question. And of course, my apologies, we need to set a target glucose, so for example 120 milligrams per deciliter, and we need to change the duration of insulin action to 6 hours. So let's go on to the same case study, and now the patient would like to carbohydrate count. We've already calculated the basal rates, we've calculated the boluses, and we've got the correction factor. We know that although it's 5 units, it appears as 1 unit on the pump, and that will lower the sugar by 40 milligrams per deciliter. So to count carbohydrates, we use the formula 500 divided by the total daily dose of insulin. That would be 500 divided by 240, which would be just about 2. So it's easier for simplicity to say we have an insulin to carbohydrate ratio of 2. 1 unit will cover roughly 2 grams. Again, we're using a pump. Pumps are not programmed to use U-500 insulin. So even though it'll say 1 unit on a pump, that's really 5 units. So we need to times that by 5. So this is actually going to cover 10 grams of carbohydrates. Again, with a pump, we know we have different carbohydrate or insulin sensitivity throughout the day. So it's probably best if this ratio is used for breakfast and lunch. Perhaps we'd have something slightly higher at nighttime, and by higher I mean it would cover more grams. Counterintuitively, we would require less insulin. So for evening, a good starting dose is typically, instead of covering 2 grams, it covers 3 grams. So even though it says 1 unit on the pump, or what we call 1 pump unit, it's still 5 units in the background. So we know this would cover 15 grams. And these are the various references I used to create this lecture. I recommend pausing here, having a look at these various papers. Otherwise, best of luck